Thank you, and good morning from Seattle. Thank you for the introduction, and it's a pleasure to be with you, and thank you for organizing this important meeting. So I want to talk about IHME projections, COVID-19 projections. The history of our model started by our university hospitals asking us to help them with their surge capacity, how many beds they need, how many ICUs, how many ventilators. And that's how we started doing this for our own hospitals, other hospitals, our county, and then eventually every state and every country in the world right now. An IHME model provides expected daily deaths in the future, of course, total deaths, but also provide an estimate for hospital needs and resources in terms of beds, ICU, and ventilators. We use mobility data from Google, as the previous speaker mentioned, Google and Facebook, and premise here in the United States. We also incorporate in our model testing, and we project as well confirmed cases and estimated infections as we go into the future, part of our projections. And we are in the third version of our model. We have realized that with this virus, as more data comes in, we need to change our modeling, the strategy, in order to capture the new data and do a better projection. So briefly here, the first model was a curve fit, which did very well in the United States, projecting the peak, but didn't do very well when we started coming down in the United States. So we switched to an SEIR model and curve fit hybrid. And the reason at IHME we didn't start with a SEIR, susceptible, exposed, infected, infectious, and removed, because early on we didn't know for many parts of the world how many people are being infected and how many people are susceptible, because lack of testing early on. And now in the third version of our model, we're doing a random knot combination spline as a hybrid model with SEIR. In our model, we use a lot of variables in our projections. Mask use, we have data on mask use. We have several variables on mask use. When you go out, do you always use it or sometimes use it? We have mobility data, as I mentioned. We see a strong association between COVID and pneumonia seasonality. So we have pneumonia seasonality in our models. We have testing per capita. We have density of the population. We have particulate matter 2.5, smoking, altitude, and pneumonia death rate. And we have, right now, we're exploring adding other variables, including some surveys that you are getting right now. When you are outside your house, how close you come to other people, how much contact you have, and humidity as well. This is our SAR model. Like every other model, I'm not going to spend time on it. One of our variables that we used early on as a key driver of cases and deaths are the mandates. And we looked at 6 mandates that every country had imposed. These mandates range from closing of educational facility all the way to airport closure. So 6 in total. As you can see, every country in the world, very few exceptions, went into these lockdowns sometimes in March. So it all happened within a couple of weeks in March. And that's what has helped countries who had less seeding of the virus early on than countries, places when they locked down, like England, as the previous speaker mentioned, and here, for example, in New York. When they locked down in New York, it was too late in a way. When Florida locked down, it was very good for Florida because there was not much seeding of the virus going on. I'm not able to advance my slides correctly, so I'm sorry about that. This is percent of people wearing masks as of August 4, and you can see a huge variation. And what's important here to notice is very high in Saudi Arabia, United Arab Emirates, and Qatar and Oman. It's very high in the Southern Hemisphere, where the COVID-19 right now, due to seasonality, is having more of an impact. In South America, for example. Less so in parts of the United States and in Canada, where we don't see high mask using. Next slide, please. This is percent reduction in mobility. We've seen reduction in mobility early on, especially with closure of school and education facilities in the United States and in many countries. Unfortunately, started April, we started seeing a rise of mobility, and right now in many places we're almost back to normal. Uh, and you could see here in the United States, the states that are most hit with COVID-19, which was on the news, Florida, Texas, Arizona, and California, you see mobility will decline automatically as there is an increase in cases. People start being afraid and they start putting up the defense mechanism, and by reducing their mobility, wearing their mask and staying away from each other when they go out. Next slide, please. This is testing per 100,000 population, and you see a huge variation in the world. Parts of Africa, not so much been going on in Pakistan, Afghanistan, as you can see. In South America, not that much as well. And a huge variation in the United States when it comes to testing, variation between the states. Next slide, please. And for each of our location, and for many countries, we can do it at the subnational level. This will be our effective R, which is changing with time for the United States, and this will be the percent infected in each state, where we estimate not only the reported infection, but what's the percentage of infection 4 months into the future until December 1st. Next slide, please. And we validate our estimates of infection compared to the studies that are being done on antibodies, with exception of a couple of studies in Spain. We're doing very well in estimating the percentage of infected cases in every location. Next slide, please. We also compare our models to everybody else model and how we perform 4 weeks into the future. We do very well 4 weeks. As we project into 4 months into the future, like every other model, our confidence interval is much wider, as the previous speaker mentioned. Next, and we release those publicly. Next slide, please. So here are some of our results for the United States. We're expecting by December 1st, we'll have 295,000 deaths. And we're providing two scenarios. The red one here will be if we keep relaxing our social distancing mandate, will be about 391,000 deaths, 295 if we enforce mandates when mortality reaches 8 deaths per million per day per state. And then the green one, if 95% of people wear masks in the United States, and we do it for every location in the world. And the idea here, 95% comes from what we see the highest, which is Singapore. They have 95%. And the 8 per million is the 90th percentile when countries and locations put a lockdown. 90% did it at 8 per million. So we're being a little bit conservative here. Some countries did it much earlier. But the results here show a huge difference. If people wear masks, we can delay a lockdown in the United States, and we can save 66,000 lives between now and December 1st if 95% of the US population wear a mask. Next slide, please. This is Saudi Arabia, for example. We are projecting 5,800 deaths in Saudi Arabia until December 1st. We don't see a need for a lockdown in Saudi Arabia, so they will not reach the 8 per million per day deaths, but 1,000 deaths less could be achieved if 95% of people in Saudi Arabia wear their mask. Right now in Saudi Arabia, mask wearing is around 75%. Next slide, please. For Saudi Arabia, we are showing here how much beds they need and how many ICU and ventilators. The red one on top, all beds available. So Saudi Arabia will not have a shortage of beds, will not even have a shortage of ICU or ventilators because they have a strong medical system. Next slide, please. This is the Iran. We're expecting in Iran, where Iran had a larger epidemic for several reasons. Iran in January had a sporting event where athletes from China came to, in January, and from Wuhan, they came to Iran. So that's how it started and spread through religious places in Iran to other places in the region. Iran, 71,000 deaths. We would expect they will go into a lockdown sometimes in October. And next slide, please. In Iran also, we expect that they will run, they will have a shortage of bed sometimes in November, in the peak of the second wave. I don't call it second wave, it's still the first wave. Second wave is we go to zero and we start over again. This wave is staying with us. It's going up and down as a roller coaster. It goes up, it comes down, it goes up again. So Iran, the second wave that will hit them, will run out of beds. They will not have enough beds. They will not have enough ICUs compared to what I showed you in Saudi Arabia. Next slide, please. One of the limitations for our modeling is excess mortality. Right now, we're modeling deaths, reported deaths by every country in the world, and we are aware from many locations where we have data on a weekly basis by cause of deaths. We know there is excess mortality due to COVID-19. We also don't know what's the percentage of people who are infected because there are no random sample surveys of antibodies for in many countries right now that done in a systematic, regular way that we allow us, all of us, to know what's happening in every country, how many people are infected, how many people have been infected and have antibodies right now. And then we have seen right now that in many places, our expectation for ICU, because there is an improvement in our ability to treat the patient, now we have less admission, less need for ICU, less need for ventilators than we started modeling early on. So it's changing as new data coming to us. And of course, whenever you see a peak of cases, what's making it hard for us in our modeling is people change their behavior and government impose mandates or dial back some of the relaxation what they have been put in place earlier on, like our state here where I live, state of Washington, started relaxing certain mandates. When we've seen a peak and several outbreaks, we dialed back some of our relaxation measures. Next slide, please. What we are needing right now, and we recommend that we need to know more about hospitalization, because when the testing is happening right now and you know how many people are positive, we don't know, are these people who sick and showed up or symptoms, or these are people from a random sample that's done on a regular basis to monitor COVID-19 in a population. So we're using hospitalization as a proxy. So we say how many people are hospitalized out of the tests that are positive, and then we know then what is the percentage of people who are tested with symptoms and as a proxy out of the total population. So hospitalization, we don't have it for every state in the US, we don't have it for every country. That has been a challenge. Getting a better handle of excess mortality so we don't estimate the impact of this pandemic. Doing more antibody surveys every month so we know what's happening, how many people are infected, and we can refine our models. Transmission early on is taking different form because of people who locked down, especially in, like the previous speaker mentioned, for a while. In April, we didn't see any cases. What happened here in many countries in the world, including in Iran, when they locked down and the cases came down and opened prematurely, the people who came out and about were very careful, wearing their mask and staying away from each other. They didn't see COVID-19 for a while. They assumed victory and they assumed there is no more COVID-19 circulating. They let down their guard and started coming up again. So we have seen this roller coaster. It goes up, it comes down. We have seen it in many states here. When people start reacting, it's behavior, it's not the virus. It's behavioral change and what the countries are doing and what the people are doing that is impacting our way. And we're noticing right now, like when we have a mandate, we have 8% increase in a short time from a mandate, what we have seen in Texas, and we have a 15% increase compared to 18 when we have a mandate and enforcement of that mandate. So it's behavior of the people themselves that changing the trajectory of the pandemic and the behavior of the government, what they do in order to stop the rapid increase of the virus. Next slide, please. So right now, what we're doing at IHME, we're providing three scenarios: business as usual, mask 95%, and a lockdown when we reach 8 per million, you lock down for 6 months. That's part of our model. It's available on our web for every country. So now people are coming to us and a lot of authorities are asking us, help us with balancing the economy and opening up for business, saving lives and saving our economy. So saving livelihood and both. What we're trying to do now, we're modeling what we call a pulse, where you can lock down for 2 weeks, open for 4, lock 2, open 2, lock 2, open 6. And then these scenarios will be available from IHME. We have them right now. They're going through quality checks, and we will release them soon on our web as well. The other thing that we have been asked to model right now is what if we close certain businesses and what will happen? So closing the bars in the United States, for example, keeping schools closed, keeping restaurants closed, what will be the impact on the COVID-19? Will a universal mask mandate and closing of certain businesses allow us to keep our businesses open until we have a vaccine available or an effective drug? And then now we're looking at how could we model the phased vaccination approach. We've been asked to set a priority for vaccination based on what the National Academy of Science is doing right now in the United States. And we've been asked to model that to show if we start rolling out these vaccines when they are available, what will happen when we vaccinate the first wave and so on. Next slide, please. Thank you very much for inviting me, and thank you for the government of Saudi Arabia to arrange for this conference. Thank you.